welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
We have Sarah Long. Sarah is a P3 pharmacy student at West Virginia University School of Pharmacy. Today, she'll be presenting a journal club on the appropriateness of antibiotic prescribing in the U.S. Emergency Department visits between 2016 and 2021.
So first wanted to note that I do not have any disclosures, neither do any of my presentation mentors. Learning objectives for the presentation are to understand the impact of excessive antibiotic utilization, to describe the prevalence and patterns of inappropriate antibiotic prescribing, and to also identify opportunities for improving antibiotic stewardship in emergency departments. So when I was reviewing the background material for this presentation, this quote was one that really stuck out from everything else. It reads, "Antimicrobial resistance has emerged as one of the most significant threats to human health in the 21st century. We're already seeing the negative effects of antimicrobial resistance on a patient, provider, system, and society level, seeing extended hospitalizations, increased outpatient clinic visits, higher laboratory demands, and extra isolation precautions. We're having to rely on second and third line therapies, which leads to longer treatment courses, more expensive medication use, and greater incidence of adverse effects for the patients." Reviewing the last report of antibiotic resistance published by the CDC in 2019, they estimated the impact of antibiotic resistance as 2.8 million infections and 35,000 deaths per year. The most common resistant bacteria that they reported in this report in 2019 were methicillin-resistant Staphylococcus aureus, or MRSA, vancomycin-resistant Enterococci, or VRE, Streptococcus pneumoniae, which is resistant to penicillins, and we're seeing growing resistance to macrolides, tetracyclines, fluoroquinolones, and Bactrim. And then Pseudomonas aeruginosa and Enterobacteriaceae are growing resistant to carbapenems. Looking further into that data, there have been certain resistant bacteria that we have seen an increased infection rate from the first report published in 2013 to this most recent report in 2019. So these 4 bacteria had increased infection rates that are resistant to their original treatment options. So Neisseria gonorrhea saw a 124% increase, increasing resistance to ciprofloxacin and azithromycin most recently. We saw a 50% increase of infection rates of Enterobacteriaceae, which mostly we saw as ESBL-producing bacteria. Thirdly, we have erythromycin-resistant group A Streptococcus saw a 315% infection rate increase, obviously resistant to erythromycin as it's stated there, but we're also starting to see clindamycin resistance as well. And lastly, drug-resistant Salmonella saw an 8% increase, so not as high as the other ones, but we're starting to see it's not susceptible to ciprofloxacin, resistant to ceftriaxone, and decreasing susceptibility to azithromycin. So to combat this increasing resistance, the White House published the National Action Plan in 2015 in response to President Obama's executive order, which outlines the steps to implement the national strategy for combating antibiotic-resistant bacteria. So this action plan had 5 total major goals. We'll focus on the first goal of preventing the spread and slowing the emergence of resistant bacteria. So to prevent the spread, we want to use vaccines for proper coverage of our patients. And then to slow the emergence of resistant bacteria, we want to use the right drug at the right time, the proper dose, and the correct duration of therapy. And we also want to see further implementation of antibiotic stewardship programs to hopefully result in a 50% reduction of inappropriate antibiotic use in outpatient settings by the year 2020. As these stewardship programs have been implemented, providers have started to develop their own view on these efforts. So this one survey of inpatient and outpatient providers surveyed their feelings towards antibiotic stewardship. We saw that inpatient providers were more likely to prescribe antibiotics when unsure of the infection source, and 1/3 of them reported that antimicrobial stewardship was not something that they felt that they could do on their own on a day-to-day basis. Whereas our outpatient providers were more likely to prescribe antibiotics for patient satisfaction, and they felt less connected to stewardship programs. So since our ED providers function in kind of both an inpatient and outpatient role, let's take a look at how antibiotic prescribing and stewardship efforts affect the ED overall. So in 2014, we saw 11% of annual ED diagnoses were due to infection. And in 2015, we saw 28 million antibiotic prescriptions come out of the emergency department. So these numbers show that infection is among the most common reasons that patients seek acute treatment in the emergency department. This study showed that multifaceted stewardship programs have shown improvement across multiple disease states. So the multifacets were personal provider feedback, implementing clinical decision-making support, and also traditional continuing education sessions targeted at those providers. Looking at a precursor study to the one that we will take a further look at in a second, was a study done to create a starting point for quantifying progress towards that National Action Plan goal of the 50% reduction. This study captured outpatient providers and ED visits through the years of 2010 to 2015. So over that 5-year span, they saw an 8% decrease in total antibiotic prescriptions per 1,000 people that they captured in the survey. And the percentage of visits resulting in antibiotics was unchanged, even though we saw a decrease in total prescriptions. The one thing to note was that inappropriate antibiotic prescribing, specifically in children, was reducing at a rate to meet that goal of 50% reduction by 2020. However, we know that in 2020, something happened to kind of throw us off that goal. We'll revisit a little bit later. So looking at the numbers on the right side of the slide, in 2010 and 2011, they concluded that 30% of antibiotics were inappropriately prescribed. In 2012 to 2013, 23% were inappropriately prescribed, and 2014, 2015, 28% of those were inappropriately prescribed. So this study created a foundation of knowledge of inappropriate prescribing practices. It captured ambulatory care and emergency department visits, so it's not totally generalizable to the patients that we see specifically in emergency departments. So that's why the authors of this study decided to take a look specifically at emergency department visits. So where the first study looked at AmCare and ED visits from 2010 to 2015, we're looking at the appropriateness of antibiotic prescribing in U.S. emergency department visits and from 2016 to 2021. The design of our study was a retrospective cross-sectional analysis of the National Hospital Ambulatory Medical Care Survey, which captures information from emergency department visits across the country. The specific data points that they captured through the survey were patient characteristics, diagnosis codes, and prescribed medications. So the authors took each diagnosis code and separated them into 3 different categories, into always justified, sometimes justified, or never justified as a proper indication for antibiotics. So our always justified diagnoses were transformed into the appropriate antibiotic use category. Our sometimes justified were shown as the potentially appropriate antibiotic use category. And then our never justified were inappropriate antibiotic use, but then they split that last category into 2 different kits, into with a plausible indication or without a plausible indication, which we'll revisit later in the results section. The enrollment into this study, they included ED visits with 1 or more oral antibiotic prescription, and they excluded visits associated with non-billable codes and visits resulting in transfer to another facility. So with the oral antibiotic prescription, these visits were most likely ambulatory patients who were discharged from the emergency department. However, we are not able to confirm that. A look at our patient population, we had a little over a majority of female patients at 57.6%. 83.9% of our patients resided in metropolitan areas. And then they broke it down by region, relatively even across the way, with a concentration in the South region of the United States. From there, they took the population and split it into 3 different age groups. So looking at children 0 to 17 years old, that was about 21% of our population. Adults aged 18 to 64 were the majority of our population at 61.7%. And then older adults greater than or equal to 65 years old were about 17.5% of the population. The statistical analysis used in this study were descriptive statistics using survey-weighted methods. They conducted analyses on the overall population and then each individual age group separately. So looking at our results, our overall percent of inappropriate antibiotic prescriptions were 27.6%. So we did not reach the goal of the 50% reduction according to this study. In children, we saw a 23.7% inappropriate prescription rate, adults 29.8%, and older adults 24.6%. So just to orient you to the graph here, we have our appropriateness of antibiotic prescribing with the percentage rates on the y-axis on the left there. The blue bar representing the overall population, the yellow bar was children, the red bar adults, and green bar was older adults. So firstly, looking at our appropriate category, we had just under 30% categorized as completely appropriate, always justified for antibiotics. Our potentially appropriate was a little bit higher, over 40% here, with children seeing the highest potentially appropriate antibiotic rates. And lastly, the inappropriate or overall prescribing here. So looking a little bit further into the inappropriately prescribed antibiotics in this next graph here, with the same layout as the last one. So looking at what was plausible and what was not plausible, we had about half of each were plausible and not plausible antibiotic indications here. So taking a deeper dive into the author's definitions of what was deemed plausible and what was not, our top 5 plausible indications were potential signs and symptoms of infection at 54% of the inappropriate prescriptions. Next was bronchitis, followed by upper respiratory infection, asthma, and other viral infections. So these conditions were deemed inappropriate for antibiotics by the authors, but some clinicians may find it plausible to prescribe antibiotics for the conditions depending on rationale that was not captured in the survey. So breaking down the largest category there of potential signs and symptoms of infection, these were the top 10 results listed as unspecified abdominal pain, headache, nausea with vomiting, dyspnea, fever, vomiting, diarrhea, pain localized to upper abdomen, cough, and pain localized to other parts of lower abdomen. The not plausible indications were listed as well. The top 10 were essential hypertension, chest pain, pain in joints, other chest pain, pain in limb, hand, foot, fingers, and toes, anxiety disorder, syncope and collapse, low back pain, major depressive disorder, dizziness, and giddiness. So the author's takeaways from the article were that stewardship efforts should be focused on reducing antibiotic prescriptions for non-bacterial infectious conditions, and improvement in coding accuracy and overall quality should occur to decrease instances of improper and inappropriate prescription status. So while pharmacists do not have a direct tie to diagnostic code selection, this may be an area that programs target for specific physician education towards antimicrobial stewardship efforts. The strengths of this article was that the data was nationally representative. So it included patients from all across the country, had a large sample size, and a diverse population. Their strength was that they broke the analyses down by age group. They highlighted viral infections and vague symptomology as a need to focus on for stewardship efforts, and they evaluated a unique area of patients that was not previously described alone in the literature. The limitations of this study were just because we were capturing survey information and not able to kind of read through the patient's charts, we were not able to assess the clinical reasoning behind the decision to prescribe antibiotics. The next one was there was an unclear weighting system. So the weighting of the patients could skew the data sets, and the overall methods section was lacking information to be able to reproduce the study. So that may be something to look into in the future. There's a possibility of under or over reporting on certain antimicrobial stewardship influences. So certain sites may already have specific emergency department stewardship programs. And there was no further information on the biggest section of these sometimes justified codes that were defined in the article. So takeaways from the article are that inappropriate antibiotic prescribing still occurs at high rates throughout the country and all ages. Errors with coding and limited information from the database may limit the accuracy of the data, and targeted interventions for proper treatment of infectious diseases is paramount to reducing antibiotic resistance. So, summary of the presentation are that millions are infected and thousands die every year due to antibiotic-resistant bacteria. Improper prescribing has not declined at the rate set forth by the National Strategy for Combating Antibiotic-Resistant Bacteria, and there are many places that pharmacists can intervene to curb antibiotic prescribing for inappropriate indications, like culture callback programs and pre-discharge prescription review. So with that, I will take any questions, and I thank you all for your time this afternoon.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.